I'm so excited to be with you all. Here's a little rundown of what our day, our hour is going to look like. I'm going to start by doing just a teensy bit of Fertility 101, just talking about like eggs and sperm and some of the terminology. Because I don't know about you all, but as a trans person, I feel like I like literally suppressed all of the memories about like reproduction and all of that when I was in school. So we're going to start there. Then we are going to look at like, what do we know? What does the data tell us about trans fertility? Then we're going to talk about fertility preservation. Then we're going to talk about hormones and fertility. I'm going to try to get to like, how can you be a good self-advocate and how can you have strong resiliency strategies when dealing with systems, including insurance, providers, etc. And I'm going to try and leave some time sacred at the end for questions. So just a little bit about me. I'm Trystan Reese. I'm based out of Portland, Oregon. I'm the director of family formation at Family Equality. Family Equality is the nation's leading nonprofit dedicated to supporting LGBTQ plus families and those who wish to form them. I'm a transgender man myself, so that's probably why I care so much about this issue. But just a little point of trivia, my dad is an endocrinologist. And he actually has specialized in trans care since before I was born. So he was literally like making up protocol in the 70s for trans people in Canada. And for a long time, he was the only physician in Western Canada who would see trans people. So people came from all over that region of the country to see my dad, who was willing to do what he could to support them. So that's pretty cool. Whenever I have any super nerdy questions, I can literally just call my dad and say, like, what is this survey or study actually saying? This data doesn't seem right. Will you look at my medical charts and tell me if my hormones are good? So that's helpful. I also have 2 adopted kids who are my older kids in this picture. They're aged 9 and 12, Haley and Lucas. And then I gave birth to Leo myself, who's the baby in that picture 2.5 years ago. Yeah, and I'm an educator at Family Equality and outside of Family Equality. I'm a really big nerd. And so I always want to know, like, what does the data tell us? What do we actually know? Because there's so much mythology when it comes to trans fertility that I'm always trying to figure out, like, what do we have research on? What don't we have research on? What do we have anecdotal evidence on? I'm connected to hundreds of trans folks all over the globe who are thinking about fertility either for themselves or, you know, just out of sort of like interest. Yeah, and so you're going to hear me talk a lot about data, but you're also going to hear me tell some of my own personal story and some stories of some other folks in my life. So yeah. Well, why is this something that is important to me? I know that when I first started transitioning, my endocrinologist, who was a pro, he was good, but he told me that testosterone was going to render my uterus an uninhabitable environment. At the time, I was 20, so I didn't care. I was like, you know, I just want a beard. I'm not thinking about babies. But as I started to get older and I started to see the people in my life like kind of partner off and like start having kids, and then I met someone that I really love, and the idea of kids started to come up. It started to really wear on me, the fact that we just don't know enough about what our bodies can do. And even though at that point I had known dozens of transgender men who'd already had babies, I still wasn't sure if it was going to happen for me. And then when it did happen for me, I really committed to bringing as much knowledge as I could to the rest of the community. And so here are some faces of people in my life who are trans parents, trans women, trans men, non-binary folks. And so I thought that would be a really amazing place for us to start, is to just like look at what is possible for us, even in a world that has told us that this is impossible. So yeah, and if there are any other starting questions that you want to put in the chat, that would be really fantastic. And I really want to name, I put this in all the materials, but I really want to let folks know this is a session that is buy-in for trans people and our partners. So if you're a provider, cool if you're here, but I'm not going to talk about how providers can be more inclusive when they work with us. I'm going to talk about how we can arm ourselves with the knowledge that we need to be great self-advocates when we're going through any kind of fertility process. So just so you know. Yes, and so another question is addressing induction of lactation for trans women. Yes, we are going to get there. So you will not be disappointed. Okay. And then the next thing that I wanted to touch on is just like, since I first created this workshop, which was for trans people 6 months ago in San Diego, I have then like, oh my God, there's all these new babies and new stories. And so someone talked about, you know, am I going to talk about harvesting an egg from a transgender man and then using that to make a baby that that his cisgender female partner carries. Yes, and that's my friend in the upper left-hand corner there, Adam, and that is their baby that they had. That was his egg, and then his wife carried the baby, and so they both have a sort of biological genetic connection to the baby. And then at the bottom, there was this really beautiful essay that a transgender woman wrote last year about what it was like to go off of estrogen so that she could hopefully have a baby with her partner. And they just had their baby. So that's them down there. And then a UK trans couple, trans man, trans woman, they had done fertility preservation pre-transition. So when they met, they had a surrogate who just had their baby. So there are just like, there are so many amazing ways that trans people are having babies on their own, intentional solo parents, with like at-home midwives, with lots of medical intervention. There's just like so many ways to do it. And I'm here for all of that. Okay, so is 35 old to be trying to have a baby for a trans man? Ooh, that's like right where we're gonna go. I'm so glad that you asked that question, Adrienne, because that is gonna be the slide after this. So interestingly enough, one of my favorite educational resources for trans pregnancy and trans fertility in general, it's actually a BuzzFeed article from a few years ago. And here's a really good like opening paragraph that they included in that article. To keep it simple, in order to make a baby, you need sperm and egg and a uterus for the embryo to grow in. Any one of those can be your own, your partner's, or a donor's. All that matters is that the sperm meets the egg and the fertilized embryo implants and then grows inside the uterus. How and where the magic happens is ultimately a matter of logistics and planning. And believe it or not, that is from an article on BuzzFeed about trans fertility. And I like to start there because sometimes we can get, it just can just feel like so complicated. And so it all just boils down to these three things, and then magic. And so talking a little bit about some of that Fertility 101, the basics. So something that a lot of people don't know is that if you have a uterus, the vast majority of people who have a uterus are born with all the eggs they will ever have. So you cannot make more eggs. You also can't really impact the health of those eggs. You kind of have what you have. And they are stored microscopically up sort of in your body. And puberty is the process through which those super immature eggs become a little bit more mature, and then they're stored. And then through ovulation, each egg, once a month roughly, one egg roughly, goes through a process of getting matured, right? So it goes from this like not useful stage to a useful stage where then it can be fertilized by sperm and then make a baby. So ovulation is a little bit like an egg processing plant. It's not a factory. You're not making any eggs. It's just taking an immature microscopic egg and putting it to the point where it can actually be fertilized and then become a pregnancy. You are born with all the eggs you'll ever have, and you start shedding them as literally from when you are born. Your body is absorbing eggs by the hundreds and then thousands. So even though you're born with several million, the process speeds up all the way until menopause. That's what menopause is. You run out of eggs and your body stops making a bunch of estrogen. And so menopause is not like testosterone-based transition. Menopause is when you run out of eggs. Testosterone-based transition, as far as we know, basically hits pause on that egg processing plant. And then when you stop taking testosterone, you're hitting play again, and your body continues or sort of like goes back to maturing roughly one egg a month, dumping it into your fallopian tubes, hopefully to have some sperm come up to it if that's what you want. Okay, and even if you're still on testosterone, your body is actually still shedding eggs. You don't need ovulation to shed eggs. That's still happening. I was kind of hoping that maybe since I hadn't ovulated for like 10 years, maybe I had like 10 years worth of eggs in there. No. Your egg supply diminishes whether you are ovulating or not. And so someone already asked, like, is 35 too late? The thing that I'll say is the number one factor that influences your fertility if you have eggs, if you are assigned female at birth, is age. way more than testosterone, actually way more than anything else. So yes, the older you get, it just means that your egg reserve is getting a little bit low. And if you're able to work with a provider, they can actually look at a bunch of other things to figure out how large or small your egg reserve might be. People will tell you anecdotally, like my mom had me when she was 40 and my sister when she was 42. Okay, well, good for them. But like one or two people on the internet or one or two friends telling you, oh, I did it with no problem, that's not science. And that's part of where mythology starts to creep in, is someone will say like, oh, well, my trans woman friend knocked up her partner, and so it should be fine if you're on estrogen. No, that's one person. And you might be that one person, but it's also important to know what's the larger picture, because sometimes we can get lulled into a false sense of security or fear based on like one or two people that we know or like a random person on the internet. So, okay, that's eggs, processing plant. Now, sperm is created brand new every 2 hours. It's a factory, it's not a processing plant. And that happens like, once puberty has started. That's going to be impacted by estrogen-based hormones, and we're going to talk about that in a minute, but that's just the difference, is that like you have a bunch of eggs, you have sperm that needs to get created all the time. So if that process is interrupted, there can be a problem. But if this is interrupted, it's basically hitting pause, unless of course you have bottom surgery. Okay, a couple of other terms that people talk about in the fertility world. I as intracervical insemination, IUI, intrauterine insemination. Those are just ways of getting sperm to the egg so you can have a pregnancy. And IVF I mentioned already. But IVF is where the body, and we'll talk about this in a second, but where eggs are taken from one body and then fertilized in a lab and then implanted back into that same body or into somebody else's body, or put on super duper cold ice for later use. And reciprocal IVF is where you take eggs from one partner, fertilize them, put them in the body of the other partner. Okay, I hope that that super 101 level of fertility introduction is okay. Okay, I'm just going to make sure that that all makes okay. Okay, someone asked again about fertility preservation and trans youth. There are some experimental things, but that's not something that I have a ton of experience in. I'm so sorry. Okay, and we are going to talk about HRT. Okay, great. All right, so I'm going to keep going. I'm going to get to some of those questions in just a second. Okay, so that's where we are there. Okay. It will surprise literally no one on this call to learn that there is not enough research on trans fertility, period. We just like need to know way more. And the reason that mythology creeps in is because we just don't have enough hard data, that we're just trying to figure it out as we go along. And so here's a sort of like visual representation of what we know a lot of, what we know some of, and what we know almost nothing about. We know a lot of for trans women, and I know M to F is like a super imperfect way of talking about trans feminine people or non-binary people who are assigned male at birth. I have to use some words for something, and sometimes the shorthand is awkward. And so I do not mean for it to be exclusive. I'm just trying to do my best with the words that we have. Okay, so what we know a lot about is fertility preservation, is what trans women can do prior to transitioning. We're going to talk about that in a second, but we know a lot about that. We know some actually about trans women and their fertility before they even transition, which is super interesting. We're going to talk about that too. We know that about 51% of trans women who have transitioned to the point of not being fertile anymore wish that they had preserved their fertility before they started on hormones or before they had bottom surgery. So that's just really, really useful, I think, for us to know. We also know some about induced lactation, which we'll talk about. We also know very little about estrogen and fertility, which I will not get on a soapbox about that, but we know very little. I'm going to tell you what we do know. And then we also know some about options for trans youth. I mentioned this already, but basically what the options they have available for trans youth are experimental because we just don't know enough. And I know that people are still working on it, but we just don't have a lot. Okay, great, I started that. So then what do we know about trans men, trans masculine people, non-binary people assigned female at birth? We know a lot about what testosterone does to the body in terms of ovulation, menstruation, all of that. So we're going to talk about that. We know quite a bit about fertility preservation. Again, very little about options for trans youth. We know some about trans lactation, not enough. And then we actually know quite a bit about trans pregnancy and non-binary identities. because I think that that's really useful too. There's a shockingly large number of research studies on trans men and fertility, including from America, Canada, and then like throughout the UK, some Scandinavian countries. There's some really, really cool studies that have already been done, and almost none on trans women. So just in case you thought that maybe you had a doubt that sexism against trans women was real, that trans misogyny was real, I can just reassure you that that is not the case. There is so little data on trans women and fertility, and that's something that I've been pushing for very hard, and I will not stop until I am dead. So, all right, so that's what the research, that's how much research we know. So then let's dig into like, what do we know then? We are going to start with fertility preservation because that's kind of chronologically how it goes. So if we start with fertility preservation really is like just trying to capture whatever reproductive material you have and then store it for later use. So for bodies that make sperm, while semen is being produced either on estrogen or not, or having stopped estrogen and any kind of other like androgen blockers, etc., you can go to a clinic and they can collect a sample. Now, if you have enough dysphoria that you're not able to, and I'm so sorry, I'm going to use some super medical terms here, and I apologize for that. If you are not able to produce a sample through ejaculation, which some people aren't, there are now a bunch of other options for you. So they can do testicular extraction, which is what it sounds like, little needle, pull it out, local thing. They can also do this during an orchiectomy. So if you're having bottom surgery, they can actually collect sperm from the testicles. Sorry, again, medical terms, I apologize. And then they can store that, and then you can use it later if you want. Or I cannot believe that a month ago, I was on Google, Googling electroejaculation. But now I have talked to 3 different providers around the country, one in New York, one in San Diego, and one in Florida, where if you're not able to ejaculate, they can actually apply a bit of electrical current, which is painless, and that just triggers ejaculation, and you're done. So there are quite a few options if you are dysphoric to the point where you're not able to produce a sample sort of the traditional way. You can store that sample at a cryobank. It costs around $1,500 a year, which to me, I'm like, that's crazy expensive. So you can go to California Cryobank. They have it's called the Pride discount. So they will give you a steep discount on sperm cryopreservation at California Cryobank. I've also personally trained their entire fertility preservation team, and I can attest that they will not misgender you. They will not use your dead name. They are extremely dedicated to doing this work the right way. You can also use one of those like mail-in things, but I don't have a lot of experience with that, and so I cannot attest to the success of that. And I know specifically, like if you're postponing transition for fertility preservation, I would not want to mess around with something that doesn't have a high enough success rate. But if that's something that you feel great about, like do it, do whatever you want. And then you can thaw and use that sample in the future for, depending on how it was collected, for any number of pregnancy options. Okay, and you may be able to do this after hormone use, but we don't know what the likelihood of that is. So we're going to get really geeky in a second about estrogen-based hormones and fertility, but the answer for now is you may be able to do that if you've already been on hormones. So hit pause if you want to know more about that. Okay, now we'll go to bodies with uteruses or bodies that make eggs. So fertility preservation for you is going to be way more invasive and also way more expensive. So in order to harvest eggs, you basically need to trick your egg. Remember we talked about that egg processing plant? You basically have to trick it into running overdrive. So you have to go to a doctor and you will give yourself a shot, and then they'll give you a shot at the end to take estrogen-based hormones to trick your body into maturing a bunch of eggs at once and then dumping them all out at once, because you want to try to get like 10 to 15 to 20 eggs. And sometimes you can do that in one go, in one cycle, which a cycle is about 16 days. Sometimes you have to do a couple of cycles depending. A couple of things to note. So the hormones that you take to sort of trick your body into producing a bunch of eggs, the estrogen is so targeted, you will not have like increased chest growth. Your beard won't fall out, your voice, nothing like that. Usually for most people, it's more the psychology of like taking estrogen. So some people are able to think about it like, you know, being a parent means sacrificing a lot for your kids. And so some people are able to see this as like, yes, this sucks and it's a sacrifice I'm making for my future family. Not everyone's able to do that, and that's okay. You do have to go to a doctor's office to extract the eggs, but it's done under twilight sedation. You're not going to remember it. But again, if the psychological understanding that someone's going to go in through the front, your genitals, and then take something out, that's too difficult for some people. They don't want to do it. They can't do it. Okay, there are other options for you. And then you store those eggs at a cryobank. And again, that annual fee is around $1,500. California Cryobank will give you a discount. And then you can thaw and use those in the future if you want to get pregnant, if a partner wants to get pregnant, or a surrogate. Okay, now, according to all the data we have, you can absolutely do this even if you've been on hormones for over a decade. So there should, number one, you have to stop taking testosterone to do this process. You have to wait until your cycle comes back, or they can even test your levels. So before you even get a menstrual cycle, they can be like, okay, good, you're ovulating. Let's do this, and then let's get this done with. So that's pretty cool. So you have to stop in order to do this. And according to all the research we have, even if you've been on testosterone for a long ass time, you can still do this. Tons of studies show this. But the newest one, which just came out in November of last year, was put out by Boston IVF. And they looked at 8 years of patient data. And they found, you can see right there, that trans men who had begun the transition process via testosterone therapy had similar egg yields as those of cisgender female patients. And I think what you're going to say there is that, you know, half of the people that they looked at. So 8 years of data, I think they ended up looking at over 20 trans men who'd been on testosterone. All of them had the same number of eggs harvested during one of these fertility preservation egg harvesting cycles. So some of them, they used their eggs to get fertilized with sperm in the lab, and then they carried the pregnancy themselves. Some, their partners carried the pregnancy, and some, they just wanted to store it for future use. And I believe that 100% of the people who used the egg to get pregnant themselves ended up having pregnancy, as did the instances where their partners carried it. Or if it wasn't 100%, it was on par with the cisgender women in the cohort that they were compared to. So just more data that shows that we're talking about hitting pause and not hitting stop. And that's very different, again, than what I've been told. I was told by my doctor, and I asked my dad, like, why did my doctor say that? And he's like, I don't know, I'm not him. But there's never been any data that shows that testosterone causes permanent sterility. Pretty useful and interesting. Okay, I am going to pop into the questions and make sure that I'm not going too fast. Okay. Oh, yes, I'm so sorry, Adrian, I didn't get to that. Cost. Oh, I wish I didn't have to talk about this, but I will. Okay, so fertility preservation, we did talk a little bit about it. Okay, for egg harvesting, it's like in the thousands, not tens of thousands, but in the thousands, 3,000 to 5,000 to harvest eggs. And it is almost never covered by insurance unless you are in the state of California, because a bill was just passed in California last year, like 6 months ago. And if you're in California and you have Kaiser of Southern California or Northern California, Kaiser has interpreted that law as meaning that they have to cover fertility preservation for trans people. So if you have Kaiser and you're in California, they will cover the entire process and they will pay for 1 full year of storage. Pretty dope. I'm going to try and take that as a precedent, and I'm going to try to go to other insurance companies, other states, and eventually federally to try and make that the case everywhere. I think that if fertility preservation is covered for people who have to go through chemotherapy for cancer, because that's medically indicated, transition is medically necessary for trans people. So we should be covering fertility preservation for trans people. Just my belief. So that is the cost of just taking the eggs out And the sperm thing, it is much less for sperm thing. We're talking about $1,000 to $2,000 for that process, depending on how many times you have to do it. And again, maybe your insurance covers it, maybe not. But Adrian, you asked about not just the egg harvesting, but then like getting it fertilized by sperm and implanted into a cisgender female partner. That is reciprocal IVF. And unless you have really incredible insurance, that is very expensive, like $15,000 to $20,000 expensive. That is why you actually see more transgender men now that people are seeing it as more possible, just getting pregnant themselves, because it's just more cost effective if they can go through it in terms of their dysphoria. So yeah, so that's the option. Okay. I'm so sorry, I'm just going to double check the questions here. Yes, we're going to talk about lactation. I'm not actually, Molly, going to talk about viability in freezing an egg versus an embryo, because that's a whole rabbit hole. So I'm not going to go there. Yes, I'm going to talk about that. Yes, okay, we talked about egg extraction. Yeah, I mean, it really is very expensive. Someone else is talking about other preferred cryobanks aside from California Cryobank. California Cryobank has offices all over the country, so they're not just California based. The only other cryobank that I have a lot of experience with, or some experience with, I'll say, is Seattle Cryobank, and only one of their staff have been through a training on trans competence that we have run. Maybe the other people have, but I'm working with them right now to get them up to speed, because I don't want to refer anyone somewhere if I do not know that those people are competent. The other option is we've done a lot of training with some of the other fertility clinics around the country, including some of the big ones. So we'll send you a link to our family building directory at Family Equality after this is done. And so that way you can see like where have we trained that we know like these folks are competent. Oh my God, I'm already halfway done with my time. Okay, I'm gonna keep going. I'm so sorry I can't get to all of your questions. All right, so what do we know about estrogen-based hormones and fertility? So what we know about really any of the estrogen-based HRTs is the fancy word is dose-dependent testicular suppressant. And when you look at the data, fertility goes like this over the course of time if you're taking estrogen-based hormones. And fertility is a catch-all term, and that means I'm talking about both like volume of semen, I'm talking about concentration of sperm in semen, I'm talking about morphology, which is the shape of the sperm. You want it to kind of have a certain shape because then you know that it's probably going to result in a viable pregnancy. I'm talking about mobility, which is like how fast they swim. All of those things really tank after taking estrogen. But what we really don't know is after that. Okay, so this happens, then what? And the last study that I found on this was a study of 2 people, 2. And I'm like, in what other medical universe would a sample size of 2 be considered good science? None. Like what trans people are subjected to medically is just like so far below par as to be insulting, and I would say offensive. So there is one study looking at who was able to regain sperm production after being on hormones. And in that study of 2 people, 1 regained sperm production and 1 didn't. Okay. But ironically enough, that's also what we see anecdotally out in the world. Anecdotally, I mean, we see cases where someone has been on estrogen-based hormones for 10 years. They stop their hormones and they're able to knock up their partner, or they're able to collect enough sperm in a lab that they're able to use IVF. But at the same time, there are other trans women who have been on estrogen-based hormones for 1 month, 3 months. They stop taking it, try to regain sperm production, and they never do. And so the reality is we don't know. And so if someone says to you like, oh, well, my partner, blah, 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 good for them. But what we see anecdotally on a big scale is probably 50%. What else do I want to say about this? And so what we know is that fertility preservation is really the best option if someone wants to become a biological parent down the line. But less than 5% of trans people use fertility preservation, even if they are adequately counseled on it. People don't imagine that they're going to become parents. That's actually the #1 reason that people give for not preserving their fertility, is they're just like, yeah, I never want to be a parent. And like, okay, when I was 20, I didn't want to be a parent either. When I was 20, I didn't think I was going to live past 22. I didn't think I would ever find anyone to love me, community love or romantic love. I never thought I would be stable enough to be able to have kids. So yeah, and I already mentioned the 51% number. So that's a little bit about what we know. Actually, that's a lot of what we know about estrogen-based hormone replacement therapy and how it affects trans women. So what options do you have? If you can't preserve your fertility because it's too late, I really do recommend, if you're able to, go see a reproductive endocrinologist, because there are still some things that they can do to help you figure out, like, okay, are you producing semen? They can look at that. If you're producing anything, they can look at that very easily. And usually that is covered by insurance. A basic semen analysis covered by insurance, considered preventative care. So if you have insurance, usually that's covered. They can just look and see, like, do you have any swimmers? If not, or if very low, they can help you go off of your hormones and try to regain some production if that's something that you want to be able to do. There are also some drugs you can take, some medicine you can take to help ramp up your sperm production. And that is incredibly dysphoria inducing and difficult to do that. I'm going to send you another link to a project I worked on with Fertility IQ, which is a website. And I interviewed 2 trans women who'd been through this process. So you'll be able to hear on those videos, you can hear their experiences and get a sense of whether or not that's something that you feel like you're able to do. Because again, it's not easy. Okay, nope, come back. Oh yeah. Oh, my animations aren't working well, but okay. So not everyone takes hormones, right? And not everyone wants to, not everyone can, not everyone has yet. So what do we know about people who have not medically transitioned, or like social transition is what they call it in the data, but socially you're trans, your friends and family know who you are, you just haven't medically taken hormones. So interestingly enough, there are now 2 studies that show that trans women may actually have lower fertility even before they've started transitioning. So even if you haven't started taking estrogen, it is probably still a good idea to go and get a sperm analysis done, because you might need some help regardless of whether you've transitioned. And I have 3 close trans women friends who actually postponed transition to have babies, only to realize that their sperm production was like almost non-existent to begin with. So they're like, great, should have found out 3 years ago, banked as much sperm as possible so that they could use, a lab to create an embryo with their partner, and then they could have transitioned 3 years ago, right? So what we're seeing now is more trans women have lower fertility could have lower fertility anyway, and there are two studies there that reiterate that fact. And then I mentioned this already: sperm analysis is usually covered by insurance as preventative care. Okay, so for folks who are assigned female at birth, what we know about people who have not transitioned hormonally is they're actually more likely to have negative experiences with providers during a pregnancy or fertility experience. To me, this seems counterintuitive, but just go with me. Okay, so I'm a man, I got pregnant, I had a baby. When I show up at a provider's clinic, they're going to look at me, and because of the way that transphobia works, they're going to make some assumptions about my identity. So they are not going to assume that I am a woman. They're going to look at me and be like, oh, okay, this is something else, and I should ask more questions about identity. But if you have not been on testosterone and you show up in a clinic, they are more likely to assume that you are not transgender or not non-binary. And what happens is then people who are non-binary or who just haven't taken testosterone have to come out to their providers over and over and over again. And that is excruciating. So if that's you, if you are going through a fertility process or want to, and where you want to get pregnant and you haven't taken hormones, it just means that you need to, like, I was going to say gird your loins, and that is the right analogy, but also not. You just need to get your people around you, because you're going to need more support than even someone like me would. You need better support people to go with you into those offices. You should think about having a doula if you're able to afford one, or if you know someone who can donate their time, because having a support person is going to be really important. And if people haven't medically transitioned, they're actually more likely to choose to lactate and nurse their babies themselves. And so they may need a little bit more support around that as well. Okay, gonna keep going. I know you have questions. I'm so sorry, I'm doing my best. But I will get to them at the end if I still have time. Okay, so for people who have transitioned, have been on testosterone, what do we know about how testosterone impacts fertility? Well, we actually know a lot. again, just like with trans women, trans men, fancy words, dose-dependent ovulation suppression. Testosterone should stop ovulation if it's being taken and administered correctly. All right. Well, that if is doing a lot of work there because I can't see you, but I'll still say, like, raise your hand if you've ever missed a shot, right? We've all missed a shot. And so if you miss a shot, either because you're a human being and you're not perfect, or because you ran out of testosterone and they were on back order, like they are right now in Portland, Oregon, where I live, or your provider was transphobic and you didn't feel comfortable going to them and you don't have another person you can go to, or you don't have money, or you don't have insurance, or you have needle phobia and it's really hard for you to do it and you just couldn't do it that cycle, right? There are many reasons why someone may miss a shot or 2 shots. Or if you're seeing a provider who's not adequately trained and they're not actually checking, like monitoring your levels adequately, right? So if you're taking it correctly, it should stop ovulation, but that's not perfect. And so we do know that some unintended pregnancies do happen for trans men, even if they're on testosterone. I personally have reason to believe that it is because they were not taking it the way that it was intended to be taken. I think if you are taking it the way that it's intended to be taken, it should keep you from getting pregnant. But again, that should is doing a lot of work right there. So what we do know is that testosterone is teratogenic, which just means bad for the fetus. So if you are planning to get pregnant, you should stop taking your hormones well in advance so it's out of your system. And if you get pregnant unintentionally, if you're planning to carry that pregnancy to term, you do need to stop taking testosterone for the duration of the pregnancy. And then again, we see this over and over and over again. Even prolonged testosterone use does not seem to impact time to conception, pregnancy experiences, or childbirth outcomes negatively. So in all the research that we have, and I've written a bunch of blog articles specifically about the research that we have, and we're going to send you that link afterwards so you can look at that data. All the research we have says that testosterone doesn't seem to impact your fertility over the long term. This doesn't mean that you're going to get pregnant. What it means is you are just as likely to get pregnant as anyone else. You may have PCOS, you may have blocked tubes, you may have fibroids, but you're just as likely to have issues and not more likely to have issues than anybody in the general population. All right, we're going to talk a little bit about postpartum, like when you can resume testosterone, but you can resume testosterone shortly after you give birth, depending on how you give birth, a genital birth or birth by cesarean, and depending on whether or not you plan to lactate. A couple of final things. It is perfectly normal that transgender men or non-binary people may choose a birth by cesarean because of genital dysphoria, right? So if you don't want to give birth through your genitals, great, don't. Lots of other options for you. And if any provider tries to make you feel bad or tries to judge you or tries to sort of, yeah, that's it. Like if anyone tries to give you shame for that, find another provider, they work for you. Same thing with breastfeeding or chest feeding or lactation or nursing, however you want to say it. A lot of trans people cannot feed their babies that way because of dysphoria. Your mental health is really, really important throughout all of pregnancy, into postpartum, and into parenting. You have to be at your best. And if you are not, that's not good for the baby. And so again, if anyone wants to shame you for that or send you anything that is not evidence-based, please invite them out of your life. Or what my mom told me to do is don't tell people how you plan to feed your baby. Don't tell people how you plan to give birth to your baby. And then side note, don't tell anyone what you plan to name your baby. So those are the 3 things I advise you to just keep to yourself. Don't tell your in-laws if you have them. Don't tell your grandparents. Don't tell people on the internet. Just say like, oh, you know, thank you so much for asking. I really appreciate your interest in the process and how things are going, but that's something we're going to keep private. You don't owe anybody else jack shit. Oh no, I'm not supposed to say that because we're going to record this. You don't owe anyone anything. Okay. Okay. So what do we know about the experiences of trans people who get pregnant? This is so interesting. It does not come from an American study. It comes from an international study. But roughly a third of trans people find that their dysphoria, if they had it, doesn't change throughout a pregnancy process. That was me. I have like some dysphoria, but not a lot. It was the same throughout my pregnancy. About a third find their dysphoria gets profoundly worse throughout a pregnancy experience, right? Which makes sense. Your boobs are getting bigger. If you have had a top surgery, your hips are getting bigger, your butt's getting bigger, right? It can get worse. And then the other third find that actually their dysphoria reduces or like completely goes away. And if we were in person, I would ask you like, why do you think that is? But since we're tight on time, I'm just going to tell you what trans people say in those studies when they pull out the quotes. They say like, yeah, I never liked having boobs, and now they're being used to nourish a human. I never liked having a uterus, and now it's being used to grow a baby. Now my partner and I are my partners if they have plural, or now me and myself and my community if someone does not have a partner. Now we're like creating a human, we're creating life. So there is that cool thing that can happen, no promises, where someone is just like, well, this is weird and cool. Now these things I would felt complicated about are being used for something really good, and it's empowering. And I share this information because I hear from trans people, they'll like DM me on Instagram and they're like, oh, I hate being pregnant. Is that bad? I'm like, no, a lot of people do. Or they're like, actually, I really love being pregnant. Does that mean I'm not really trans? No, a lot of people do. So like whatever your experience is, it is normal if normal is a thing. And other people have been through it, and you just need to find support so that you don't feel alone in the process. And then what we hear is people really have to choose between 3 different things. And you can basically have 2 out of the 3. You can have support around your pregnancy. You can have affirmation of your identity. You can have feelings of safety, right? So you can choose to go stealth as a cis man and not tell anyone that you're pregnant. Okay, then you have affirmation of your gender identity and you're safe, but you're not going to have the support around your pregnancy, which I promise you, you need. Like you have to be able to go see a provider. You have to be able to talk to people about being pregnant. It's such a weird experience. You need support. You can go, you can basically navigate through the world as if you were not a transgender man and as if you were a cisgender woman, right? And not tell people that you're non-binary or trans, and then you'll get support around your pregnancy and you'll feel safe. But there's this whole part of your identity that that's not getting affirmed, and that's going to have major psychological impact. And then the final option is to do what I did, which is to just like tell everyone I'm a pregnant trans man, and then you have support around pregnancy, affirmation of your gender identity, and you're going to feel profoundly unsafe and will probably be targeted. So those are your 3 options. And then you have to choose what's going to work best for you. And whatever you're not going to get because of how you're managing to survive, find ways to get it. So if you're not feeling safe, bring in the cavalry. Like ask your friends to monitor your social media for you. If you're not getting support around your pregnancy, join trans pregnancy groups on Facebook. If you're not getting affirmation of your gender identity, find communities where you're going to have that, because you're going to need all 3 and you're not going to be able to get all 3 easily. And all the data, just like feeling lonely, that's like the most common theme. So know that going in, and know to like try and find community and prepare for that ahead of time if you can. Super interesting fact, 22% of trans pregnancies in the strongest study on trans pregnancy happened out of hospital, either in freestanding birth centers or at home. So it is totally normal. Everything is normal. But a lot of trans people opt for an out of hospital birth, which is huge compared to the US average for that year. And so a few things I'll say about this: not every person, not every pregnancy is right for a home birth or even a freestanding birth center birth. So just make sure that you have a provider you trust who can give you evidence-based information on that. The other thing is that it can be very traumatic to have a birth that doesn't go according to plan. And it can be doubly traumatic to have a birth that doesn't go according to plan and then have to go to a hospital where you don't feel comfortable or safe. So even if you're planning to have a home birth, I really, really, really recommend at least touring the hospital that you would get admitted to, just in case you need that level of extra support if there is an emergency that happens. Sometimes people feel like, oh no, I don't even want to mention a hospital. And I'm like, no, that's not science. Mentioning the hospital, touring the hospital is not going to magically make you more likely to be admitted to the hospital. No, it's going to mean that if something happens and you need to be admitted, you're going to feel more safe, more secure because you've met those people, you know those hallways. It's going to be a little bit smoother for you. And I tell the same thing to doulas, that they have to stop shaming people for the hospital thing. So yeah, and then of course this surprises nobody, but trans people have a high level of discomfort with medical systems. And so again, figure out going in, what do you need to feel safe? All right. Okay. So we are going to talk about lactation. So if someone has had top surgery, regardless of the top surgery procedure you have had, you may still be able to produce milk for your baby. What? I know. Even if you've had periareolar, even if you've had double incision, even if you've had keyhole, doesn't matter because bodies are amazing. So sometimes even if nipple off, back on, those milk ducts may still find the nipple and produce milk, which I think is just like super cool. So if that's you, if you have had top surgery and your body does produce some milk, a couple of things to note. If you've had top surgery, the pregnancy may still cause some issues with your surgery scars. You might need revisions because some of those milk ducts may hit scar tissue and you might have some puckering. Some of that goes away, some of it doesn't. So sometimes people ask me like, should I wait until after I've had a baby to get top surgery? Your decision. And people sometimes do need to have revisions afterwards. And another thing is you can get a thing called the Supplemental Nursing System in SNS, and it's a little bag of milk and then a tube, and you can tape it to your nipple. And then the baby can suckle and then get some milk from you, and then also from the supplemental system. That can help you produce a little bit more milk. I've never seen a case where someone who's had top surgery is able to produce all the milk their baby needs for nourishment. So you are going to have to supplement in some way. So whether that's the case, or you've had top surgery and you're not able to produce milk, or you just don't want to produce milk and feed your baby that way, then you can supplement with formula. And again, if you want to supplement with formula because that feels great to you, if you have a provider that shames you for that, get a new provider. If you have a person in your life who shames you for that, get a new friend. I'm just kidding. You don't need to fire your friends. But you need to surround yourself with people who are going to empower you and are going to support you in the things that feel great to you. If you are going to do something wildly unhealthy or unsafe, sure, intervene. But a lot of these things, it really is about choice. So you can formula feed. Your partner can induce lactation, even if they're a transgender woman, using the same Goldfarb method that any other cisgender woman would use. And I believe there's been one case of a trans woman who is able to produce enough milk to feed their baby exclusively that way. Most people aren't able to produce enough to feed their baby that way, but enough to have that cool experience. And it can be extremely affirming, obviously, for a trans woman to be able to do it that way. And then, of course, you can use milk banks or peer-to-peer networks. And again, that's up to you and your decisions around what feels safe and empowering to you. That's not something that we did because I was worried. I don't trust people, just generally speaking. And I didn't trust people. I didn't want to feed my baby a stranger's body fluid. That's how it felt to me. Other people are like, this is amazing. Like all these people are contributing to the nourishment of my baby. Isn't this a beautiful way that community can show up for our family? Both are exactly right. Both are exactly perfect. As long as the baby is getting the nourishment they need, that's what matters. And that your psychological safety is intact. Okay, I'm going to look at the questions to make sure I haven't done anything. I haven't done anything egregious. Okay. Boop, boop, boop. I'm going to talk about insurance. Yes. Yes, Sebastian. Absolutely. You can still get pregnant even after a decade on testosterone. And the best study on trans fertility, and again, I wrote an article about it, we'll send you the link, is the LIGHT study from 2014. Over a third of the men in that study had been on testosterone for more than 10 years. They had the same time to conception as anyone else. They had the same pregnancy experiences as anyone else, the same birth outcomes. So not bigger babies or smaller babies, no more likely to have gestational diabetes. There were nothing. They're in alignment with everyone else. So yes, you can still get pregnant even after a decade on T. I did. I was on testosterone for 12 years and I had my baby, who I think is very cute. But that's just me. Okay, anybody else? Someone's asking, what are the visible signs of sperm production or concentration? No, it's microscopic. You have to go in, they have to look at it under a microscope, sorry. Oh, yeah, so we've got a couple of questions about that. And then the doctor you would see to find out your sperm count, you could go to any fertility clinic can do this like that. Any cryobank can do it. No primary care providers, I don't think, but they can give you a referral to an endocrinologist, a urologist, a fertility clinic. If you're in any big city, you should have like a CCRM Seattle, which is a big fertility clinic, an RMA New York. any of those clinics would be able to do that for and with you. Okay, I'm gonna keep going. Oh, I'm so sorry. Oh, okay, Max, because we were just on this. What if your body produces milk, but you don't want to feed your baby that way at all? That was me. And what you need to do is try to suppress your milk production, which is basically impossible. Some crunchy people will tell you, like, take this herb or put this thing on your chest. Maybe, but really, you just have to not feed your body that way. And after 1 to 2 weeks, your body starts making milk. It's the same as people who are surrogates, right? They suppress their milk production, or maybe they pump some and then suppress their milk production. Same as people who are giving their baby for adoption, they just suppress the milk. Yeah, and so there are ways to do it, but basically you just don't touch the nipples and then it'll slowly go back away. Okay. How probable is it that you can produce milk if you have had top surgery? That we don't have enough data on, but some, I know that's not very helpful. Okay. All right, I'm going to keep going, friends. I want to answer all of your questions. Okay, starting back on hormones or starting hormones for the first time, if you weren't on them before. If you've had a birth by cesarean, you can start hormones pretty soon after giving birth. Testosterone promotes the production of red blood cells, which is actually really good for healing scar tissue. So it can actually help you heal if you've had a birth by cesarean. So you can do it pretty early on. If you had a genital birth or a birth without cesarean, it is recommended that you wait 6 to 8 weeks because your body gets this rush of estrogen to heal the wet tissues. Estrogen is critical in healing wet tissue, which is going to help you heal from childbirth. And by the way, those recommendations, purely guessing. This is scientists, academics, and medical providers making assumptions based on what we know about how the body heals postpartum and what testosterone and estrogen does. We do not have standard protocols for this. So if you're like, I'm literally starting testosterone the day after I have this baby, okay. If you're like, no, I really want to wait and make sure everything is good, okay. Again, this is all recommendation. This is what we know based on what we know. But there's no studies on this specifically, unless you're nursing. If you would like to feed your baby, the first 3 to 6 months of milk production is entirely hormonally driven. So if you start taking testosterone, your supply is going to tank. So you won't be able to feed your baby that way. After supply has been established 3 to 6 months, we do not know whether testosterone carries over into human milk. We do not know if it can be processed orally by an infant. We do not know if it carries over and is enough to impact the infant's system. So some people in the field are like, yeah, being on hormones is very good psychologically and physically for trans people who want to be on them. So that's a known benefit versus an unknown risk. We don't know if it's going to impact a baby. So people should just go on testosterone. Other people in the movement are like, okay, well, maybe we shouldn't possibly be giving testosterone to babies. We just don't know enough, so let's not do it. So there is no standard recommendation. My recommendation is wean your baby onto a bottle and go on hormones. But that's just me, and that's not right for everyone. So that's the common thinking on that right now. Okay, that's all the body stuff. Oh my God, we have 4 more minutes. Okay. Insurance and medical care. I kept the F on my insurance because I didn't want to have to escalate if any of my claims were denied. I hate that. I don't want to be on the phone with somebody. I would rather be misgendered on the phone than have to tell someone to file a claim. They're not supposed to do that because of the ACA, but they do. Okay. Well, I'm gonna have to keep going. Have a good ally and tell them what you need them to do, which could be advocating on your behalf, educating people so you don't have to, blocking horrible people from you, being aware of prenatal anxiety and perinatal mood disorders, supporting you during labor. I have a whole tool for how to stand up for yourself with medical providers. I'm not going to get to this, but I did write an article about it and I made a video about it, so that will be the link. Oh no. Okay. I'm just going to go to questions now because I love you and I want to answer your questions. Okay. The method for inducing lactation is called the Goldfarb method. I have trained a ton of midwives around the country, all of whom pretty much any midwife should be able to help you with inducing lactation, because it's something that a lot of people do, like adoptive parents, lesbian partners, all of that. So yes, they should be able to do that. Okay, Miles, you're asking for advice on how to talk to families when they don't understand how you could transition and have a baby. I mean, I started the conversation with my parents about having a kid years before it really happened. And it actually happened weirdly because my mom had a friend whose trans son had a baby. And she was like, would you ever want to do that? And at the time I was like, hell no. But times change. But so she had already been thinking about it. And then I did start talking to both of my parents about it long before it really happened to prepare them. And I think there's a few different ways to go about it. You know, I think it's how we could have a family works a lot. To be like, look, we desperately want to become parents and we have some of the parts we need to make a baby. So we're going to make the sacrifice and use the parts we have to make a baby. And I understand that it might feel confusing to you that I'm saying I'm a man and I'm getting pregnant, and that confusion exists in your mind. It does not exist in my body. I am totally okay being a special kind of man that gets to create life. And lots of other men don't get to do that. And I think that's pretty cool. And I welcome your involvement in this pregnancy. And I welcome your involvement in my life when you are ready to do that in a positive way. So that's kind of what I did. Yes. We don't know about bottom surgery. So we haven't had a single trans pregnancy study that has talked about bottom surgery. So we just don't know yet. Sorry about that. Teddy, I kept the F on insurance, but not on other documents. When I signed up for insurance, I just put female on the form and that was it. And then after I had the baby, I went back in and I was like, hello, I'm transgender. Can you put the M on my documents now? And they were like, sure. Do you have the paperwork? And I was like, yep. So yes. Okay. Research on medical complications for children from sperm produced after taking estrogen. Like sperm is sperm is sperm. And so other than some of the other things, like we know estrogen can impact like the morphology and things like that, if you do IVF, they're looking at the sperm under a microscope. They're going to pick healthy sperm. And in fact, when you give a sperm sample and they store it, they do what's called sperm washing, where they get rid of all the crappy sperm. I don't mean to say your sperm is crappy, but any sperm that is in any way not healthy enough to create a viable pregnancy, they're going to get rid of that. So the sperm that gets saved is going to be healthy sperm. Same thing with eggs. Like once you've been on testosterone, doesn't matter. There doesn't seem to have any long-term impacts on the eggs, which I know seems wild, but here we are. Okay, so this person, they know that their fiance has eggs that are swimming after stopping estrogen. They don't know if their eggs are ready to go after having 3 periods. How would you know? You don't. Sorry. You can go to an endocrinologist, and it's usually covered under insurance to have a fertility workup. And that's preventative care. So if you have insurance, they will do a fertility workup on you. They'll use an ultrasound. They can check your follicles. And looking at your follicles, how many you have, they can usually say like, yeah, you're good to go. The general recommendation is to wait 3 healthy cycles to start trying. You've had 3 healthy cycles. So as far as we know, you can start trying. According to the, I'm already 1 minute past. I'm so sorry. Okay. I want to get so much more detailed in that. And what I want to do instead is to just say thank you all so much. There are a lot of questions that I didn't get to. I'm so sorry. Maybe next time we'll do 90 minutes. I didn't know if anyone was going to even come to this one. Oh my God, we have 50 people here. Okay, yay, people came. So then I think we can do a second one. And we can do a 90-minute one, and y'all can send me emails, and we're going to send you a link that will show you all the articles that I've written. I just get into the data and I'm like, this is so sciencey. How would a normal person even know about what any of this means? Cool, I have called those researchers and I've been like, I don't know what this study means. Can you tell me? Or the research has been behind a paywall, and I will email the researcher and be like, hey, can I have this? And they're like, sure. And they'll send me the study. So I've gotten access to a lot of the stuff that maybe other people wouldn't. So yeah. Yeah, we're going to send you a follow-up email that is going to be from Family Equality that will say like send you some of this data and videos. You can always email me with extra questions. You can send me a DM on Instagram. You can follow my family. Right now, also Family Equality, I'm overseeing this whole calendar of events for parents and prospective parents who are LGBTQ+. We have a panel specifically on sperm donors in 2 days on Wednesday nights. So if you want to know more, it's California Cryobank. The guy's going to be there. A midwife will be on as well, a home birth midwife from San Diego that I'm obsessed with. A lawyer will be there. Some of you asked some legal questions. So if you want to get deep in the nitty gritty of working with a sperm donor, that panel exists and will be trans inclusive and trans friendly. And then we're going to continue to build these events for prospective parents to help you figure out the mystery of all of this. And then I just want to end on the final, one of the final photos of like all the amazing trans families, because I will just say that for me, being a parent has been just like one of the greatest gifts that I never could have imagined I wanted or I would ever get. And I feel like building a family is one tiny way that we get to build these little empires of love around ourselves to protect us from transphobia and homophobia and racism and everything that we have to deal with every day as trans folks. And I want everyone to be able to do it if they so choose. No pressure, but if they so choose. Yeah, so anything I can do to help make that happen, let us know how this event was. Fill out the survey. That's really helpful for making me advocate for more trans programming. And I love you all so much. I'm accountable to you. If any part of this didn't work for you, if you want me to use different words, more of anything, less of anything, please tell me, because you are who I serve. Even though I work for Family Equality, I serve you. So thank you all so very much and have a lovely rest of your week.